Hi everyone, welcome to my presentation. My name is Maneh S and I did my plan change project on reducing surgical site infections. Here is the table of contents. As you can see, we have a lot of ground to cover. I will be applying Ronald Libet's 7 phases of change theory throughout my project and a little bit about the theorist. Ronald O. Libet was an American psychologist whose change theory was later published in a book entitled The Dynamics of Plan Change in 1958. Identification/significance of the problem. We're going to be applying phase 1 of Libet's theory, which is becoming more aware of the need for change. According to the CDC, in the U.S. alone, approximately 157,500 surgical site infections occur annually. The CDC also confirms that surgical site infections are not only the most common type of healthcare-associated infection, comprising of more than 20% of infections, they are also the costliest, surpassing $3 billion annually. The CDC states that approximately 50% of all surgical site infections are preventable using evidence-based strategies. Additionally, surgical site infections are the leading cause of readmissions to the hospital following surgery, and approximately 3% of patients who contract a surgical site infection will die as a consequence. According to the Journal of American Medical Association, patients with surgical site infections stay in the hospital 7 to 11 days longer than patients who do not contract a surgical site infection. Supporting the need for the plan change. So we're seeing a lack of adequate infection prevention practices by nurses according to the research. In fact, in Tesfaye's 22 cross-sectional study of 402 randomly selected nurse participants, only 39.6% of nurses had infection prevention training versus 60.4% who had no training. The researchers quote, "Nurses who had taken IP training in this study were 2.5 and 2 times more likely to have good knowledge and a good attitude towards surgical site infection prevention activities than their counterparts, respectively. Thus, this question warrants further research for surgical site infection reduction strategies among nurses." Furthermore, in Amadipour's 2021 study on barriers to hand hygiene compliance in ICUs, barriers such as lack of knowledge of hand hygiene practices posed as a frequent problem among nurses. Again, this provides further supporting evidence in the need for the plan change. Analyzing the potential for success of the plan change. So many successful studies have been done, as you will see in later slides, implementing a change method to reduce surgical site infections through improved surgical site infection prevention by healthcare workers, including nurses. So we are seeing this potential for success through peer-reviewed journals. And factors that will enhance the achievement of the identified change include compliance and a positive attitude towards the change by nurses, and this is actually phase 2 of Libet's theory, and commitment to the change by a change agent. A change agent is an individual responsible for leading the change process, which actually coincides with phase 3 of Libet's theory. And then factors that will detract from the achievement of the identified change includes non-compliance from staff and a lack of willingness to accept the change. The databases used for the review of the literature included the National Library of Medicine, Science Direct, the World Health Organization, the Center for Disease Control and Prevention, and CINAHL. Key terms used included surgical site infections, surgical site infection prevention training, nurse knowledge on infection prevention, nurse training on infection prevention, reducing surgical site infections in the hospital, hand hygiene compliance, and nurse hand hygiene. In our plan of action, we will be considering 3 different approaches: direct observation, interprofessional task-based training, and simulation-based training. In the first article, we see the direct observational approach being used. The summary of the article states, an 8-year observational longitudinal study was done on hand hygiene practices among interprofessional healthcare providers, namely doctors and nurses in medical and surgical wards in tertiary hospital in Finland. The study monitored hand hygiene compliance among 24,614 nurses and 6,396 doctors through direct observation from 42 trained infection controlling nurses. After 8 years, the results revealed an increase from 10.8 to 86.2% in hand hygiene compliance in medical wards and an increase from 32.7 to 67.6% in surgical wards. Among nurses in both medical and surgical wards, hand hygiene compliance increased from 17.8 to 81.6%. In terms of hospital-acquired infections, medical wards saw a decrease in hospital-acquired infections from 15.9% to 13.5%, and surgical wards saw a decrease from 13.7% to 12%. In a second article, we see the direct observational approach being used again, with the inclusion of the infection control link nurses as the observers. In the study, the researchers provide a quasi-experimental method involving 154 nurses from Iran. The participants were then divided into two groups, the intervention group, who used the infection control link nurses, and the control group, who used the standard hospital approach. The results indicated an improvement in hand hygiene compliance among nurses in the intervention group that improved significantly from 18.8% before the program to 37.32% 6 months after the program. And a little bit of a comparison between the two articles. While both studies use the direct observational approach to observe hand hygiene compliance, Ojan Perez design was strictly observational with no implementation of randomization, whereas Gorbanomov's was quasi-experimental with randomization and a control group. In a third article, we see the interprofessional task-based training method used in the prevention of surgical site infections. 145 participants, comprised of nurses, doctors, and technologists from Shifa Hospital in Islamabad, Pakistan, were used in this mixed method study. Participants engaged in an 8-week surgical site infection prevention training course, followed by an end-of-training questionnaire. Pre- and post-test scores on infection prevention knowledge were also executed. The results of the study indicated an improvement in overall knowledge scores and positive response in working with interprofessional groups with a common goal to prevent surgical site infections. And a little bit of a comparison between all three of these articles we've read so far. This current one did not produce any data on actual reduction in surgical site infections, unlike the first two articles. The authors, however, find that application of task-based training would show promising results in terms of surgical site infection reduction. In the fourth article, we see a journal review of 27 articles analyzing the use of simulation-based training in the prevention against hospital-acquired infections, including surgical site infections. I'd also like to make a note that surgical site infections are under the broader umbrella of hospital-acquired infections. Simulation-based training was directed by doctors, nurses, infection preventionists, and simulation staff and included training such as hand hygiene, standard precaution, and surgical site infection prevention. The results indicated that SBT improved learners' sense of competence and confidence, increased knowledge and compliance in infection prevention measures, decreased hospital-acquired infection rates, and reduced healthcare costs. And comparing this article with the previous one with the task-based training method, this simulation-based study revealed an overall increase in surgical site infection prevention knowledge like the previous one. However, this study provided no actual training, but rather a review of past simulation training studies. Consequences of each approach. Direct observation can fall prey to biases such as the Hawthorne effect, which is a change in behavior under the knowledge that one is being followed or monitored. In interprofessional task-based training, there is no data on actual application of preventative practices after training, only positive feedback in working with interprofessional group members and an increase in knowledge of prevention practices. And in simulation-based training, there may be a lack of realism and an inability to apply in realistic situations 100% of the time. Ranking each approach. In third place, we have interprofessional task-based training. While increase in knowledge of infection prevention practices may translate well into practice, there is not enough research to support. And in second place, we have simulation-based training. Across the 27-article journal review, we repeatedly see success in simulation training for the prevention of hospital-acquired infections, with quantifiable data showing a decrease in hospital-acquired infections in practice. However, even stronger in evidence is direct observation, ranking in at number 1. According to the literature, there is strong statistical data in favor of direct observation through infection control link nurse programs, as we saw in the evidentiary support in the first two articles. Ojan Perez's large-scale observational study provided the strongest evidence for best practice. The results indicated an increase in hand hygiene compliance and a decrease in hospital-associated infections, including surgical site infections, over an 8-year period. In the second study, we see a success as it revealed a 50% increase in hand hygiene compliance over a 6-month period. So, direct observation is recommended for best practice. Other researchers even state direct observation is the gold standard of hand hygiene compliance to prevent infection. Expected changes for the plan change project are very simple: increase in hand hygiene compliance and a decrease in surgical site infections. Peacock question. In working with clients who have undergone surgical procedures, will direct observation of nurse hand hygiene compliance by infection control link nurses decrease the number of overall surgical site infections compared to the standard procedure of surgical site infection prevention within 1 year? This slide is in line with Phase 4 of Lippitt's change theory, in which you set change goals and action plan for achievement. Policy and protocol for practice change. The hospital will implement an infection control link nurse program in which the infection control link nurses directly observe hand hygiene compliance of all nurses working with surgical patients during and after surgery for 1 year. Rationale: direct observation is the gold standard of hand hygiene compliance to prevent infection. Procedure. Observations of the nurse by the infection control link nurse include observing hand rubbing using an alcohol-based sanitizer and hand washing using soap and water. Rationale: the World Health Organization's evidence-based guidelines recommend specific length in hand rubbing 20 to 30 seconds and hand washing 40 to 60 seconds. Observing hand hygiene moments: before touching the patient, before a clean or aseptic procedure, after body fluid exposure, after touching a patient, and after touching patient surroundings. Rationale: the WHO's 5 moments of hand hygiene are 5 moments that nurses must perform hand hygiene to reduce the spread of infection to the surgical site. Intervening if incorrect procedure is performed. Rationale: it is the duty of nurses to do no harm, non-maleficence. And finally, the infection control link nurse will provide feedback and evaluation to the nurse at the end of the observation. Rationale: feedback from an experienced nurse is important in the improvement of the novice nurse knowledge and procedural technique. Phase 5 and 6 of Lippitt's theory, which are implementing the change and staff accepting the change, are in line with the implementation aspect of the plan change project. With approval from the hospital chief, the director of nursing would be directing the program and hiring the infection control link nurses. Prior to the start of the program, surgical site infection incidence rates will be collected from the last 5 years using the hospital's EMR system. Pre-assessments on infection prevention knowledge will be provided to all nurses working with surgical patients. When the 1-year program begins, the infection control link nurses will follow the procedure from the previous slide. Infection control link nurses will keep a record of observational data of hand hygiene compliance for each nurse, and data will be collected each month reflecting hand hygiene compliance. In the final stage of the plan change, also known as the evaluation stage, incidence rates of surgical site infections from the 1-year program will be computed using the hospital's EMR system and compared with incidence rates from the past 5 years to see if surgical site infection rates did in fact decrease. Post-assessments will be provided to measure improvement in infection prevention knowledge. Also, comparison rates of hand hygiene compliance from month 1 of the program versus month 12 of the program will be measured. And last, program feedback forms will be provided to nurse participants. In addition, the evaluation stage coincides with the final phase of Lippitt's theory, Phase 7, in which we redefine the relationship of the change agent and the system, the change agent in this case being the infection control link nurses. If the program is effective, in other words, if there is an increase in hand hygiene compliance and a decrease in overall surgical site infections, the hospital may decide to integrate the infection control link nurse program permanently with any necessary adjustments. Some final thoughts about my plan change project. So we're all aware that healthcare facilities have varying approaches in making sure their healthcare workers are compliant to hand hygiene standards. And during rotations, I learned that some hospitals have secret shoppers, also known as anonymous observers, who scour facilities every month to ensure that their employees are compliant. And the sheer fact that surgical site infections cost the US a whopping $3.3 billion annually with increased mortality rates is enough reason to implement programs to increase proper hand hygiene compliance. And I'm convinced through this project that direct observation is an excellent approach to do just that. And as nursing school has emphasized time and time again, hand hygiene compliance is extremely vital to patient care and should be reinforced in healthcare facilities across the globe. Thank you.